sure. Other of those, that what's called the hypothalamus pituitary and axis, which the hypothalamus sends a message to the pituitary gland, which then sends a message to an organ to create those hormones. And that's um, what we're going to be talking about. Okay, so these systems, all of these systems work in what's called a negative feedback. So the body is trying to maintain a balance of a level of a certain hormone, whichever one we're talking about, or a certain blood level. Like for diabetes, we're trying to keep the glucose in a certain level to support body function. And if that level or variable or whatever we're measuring gets too high, then that is a message that will decrease the stimulus to tell the body you don't need to make any more of this hormone because we have enough. And then if the we need where that variable, that level is getting too low, then that's a stimulus for the body to create more. Um, I'm not sure what to tell you guys. Okay, so okay. So the first thing we're going to talk about is diabetes mellitus, and in this case, um, depending on what kind of diabetes you have, either diabetes type 1 or diabetes type 2, the body is not creating enough insulin to meet its needs. It just depends on what the cause is. And this is again an example of a negative feedback system. The body is trying to maintain homeostasis, which is to keep the blood sugar between around 100 to 70. It depends. It always depends on which lab you're talking about, which hospital system. There's always a subtle change in whatever the normal range is. But about this, because we need to have a certain amount of blood sugar always circulating to, especially to feed our brain and the metabolic processes in our body, because we can't create ATP without it. And ATP, or adenosine triphosphate, is the energy source for everything in our body. So we're always trying to maintain this level. If the blood sugar starts to get high because we ate or something of that nature, then the body, the pancreas, will release insulin. And insulin has several jobs. One is, as this picture illustrates, it is the key that allows glucose into the cell. And if we can't do that, then the body can't use it for metabolic needs. So we need that. Even if we had glucose available, the cells can't use it without the insulin. Because this is America, obviously we usually eat more than our bodies need. So the insulin will help with that as well. We'll store sugar in the liver to be used later in times of as the blood sugar gets lower. And then if we fill up the storage of the liver, then it is stored as fat, as triglycerides. So then if we're between meals and the blood sugar starts to get low, we certainly wouldn't release insulin anymore. We would release the counter hormone, which is glucagon. And glucagon is the hormone that we need in order to access our storage in times that we don't have enough glucose. So glucagon will, um, encourage a process called glycogenolysis, which breaks down the liver stores so we get what's in the liver. And then the other thing it'll do is it'll use fat to create sugar, which is the process called gluconeogenesis. So it'll try to convert fat into sugar because the brain can't live without it. Unfortunately, the byproduct of that creation is ketones, which is an acid. So that's how the body works to maintain that, and it's the pancreas that makes those hormones in its islet of Langerhans, because the pancreas has both endocrine and exocrine functions. It helps with digestion, but also creates those hormones that are necessary to maintain blood sugars. And this is just a picture of the area. This is the area of the pancreas that makes the digestive enzymes, which is the biggest job of the pancreas. These islets of Langerhans, that's the part of the pancreas that makes the hormones. So for some people, they get a diagnosis of diabetes mellitus, which is essentially meaning sweet urine. So don't worry, you don't have to do that anymore. You don't have to taste test urine for sugar, but that's how it got its name. So if your fasting blood sugar is greater than 125 on 2 separate occasions, that would support a diagnosis of diabetes. If you have a hemoglobin A1C, oh yay, Emily. If you have a hemoglobin A1C that is greater than 6.5%, then that supports the diagnosis of diabetes. The OGGT is an oral glucose challenge test. That's really the definitive test for diabetes, but not everybody uses that. There is a difference between type 1 and type 2 diabetes. Type 1, which is considered juvenile onset, although it can happen to adults, is a failure of those beta cells. So there's no insulin. And it's the body's own immune reaction to the pancreas. It's an autoimmune issue that causes breakdown of those cells that create insulin. And so the only way to treat type 1 diabetes is to actually give insulin. Type 2 diabetes is associated with obesity, and it's just a lack of sensitivity of the pancreas, not realizing that the blood sugar is getting higher. So decreased sensitivity of when to release insulin. And it's also insulin resistance at the cells level. So it takes more insulin to allow glucose into the cell than it used to. And I always think of this as sort of a sensory, like when you think about people that go, say you went into a room where someone wore a really, really strong cologne, and you thought to yourself, wow, that smells terrible. But the more you sit in that room, you don't really smell it anymore. You get sort of sensitive. The sensitivity of the smell decreases. And that is kind of how I picture what happens to the body. It's so used to being bathed in glucose, it doesn't respond as well to the increase in glucose as it did before. So anyone who's diagnosed with diabetes mellitus, no matter what the type, should have some kind of plan for what they're going to do if their blood sugar gets too low. Because when you're diagnosed with diabetes, we know that the goal of treatment is going to be, okay, I'm going to need to take medication of some sort that's going to bring my blood sugar down. But if that's the case, then I increase my risk of hypoglycemia. So I should have some kind of plan, something I'm going to do to bring my sugar up rapidly and have it near me in case there's a problem. And we'll go over that in a couple of slides. The person should have a diet and exercise plan. They should be decreasing their overall carbohydrates and sugars, and they should be increasing their exercise, and they should always wear a medical alert bracelet, because if they're ever found down, that's one of the first things that anyone who's a first responder should be checking, then, is their blood sugar. So the main question here, and what you're going to need to know as well for the exam, because you need to know if a question is asking based on these patients' symptoms what to do, are the symptoms of hyper and hypoglycemia. So what are those symptoms? If the patient's blood sugar is very high, what symptoms do they usually have? Yes, they can be because they get very dehydrated, potentially. They can have an altered level of consciousness besides confusion, especially at very high levels. So we typically describe them as high and dry. When the blood sugar gets really high, the patient really will get very dehydrated. So, and in an effort to try to correct that, the patient will experience increased thirst, increased hunger, and increased urination. So what we learned was when I went to nursing school is it's the polys. Polyuria, which means going to urinating more. Polyphagia means wanting to eat more. And oh my goodness. Polyphagia, polyuria, polydipsia, wanting to drink more because they feel so dehydrated. And then the symptoms become what Scott's talking about, where they start to get very fatigued and then they might have some mental status changes. What about hypoglycemia? Could be. And actually, the end point of both hyper and hypoglycemia is kind of the same, where they could have some sort of mental status change that ultimately could lead to coma or them not being rousable. The difference is that the patient who is hypoglycemic is not dehydrated, and so they will be sweaty and shaky, and that's a key difference. So put stars around that, especially when you're trying to answer a question for an exam. If the patient is irritable and sweaty, kind of shaky, that's the early symptoms of hypoglycemia. If the patient is feeling just kind of dehydrated and dry and they're doing the urinating and the hunger thing, and then that's more of a hyperglycemia. So be sure you're able to understand the distinction. And then if the patient is hypoglycemic, they have several options depending on how awake they are and how able they are to follow directions. So if the patient's awake, then the treatment would be to eat something, and you need to have 15 to 20 grams of sugar as fast as you can. And the way to do that would be to take things that are full, that are high sugar in sugar. So 4 ounces of orange juice, saltines, honey, something that the person can get right away. You can also get like gels and glucose tablets that people carry just to be sure they could take care of that if they can. Certainly the person has to be able to be awake enough to take something by mouth and to be able to swallow. Other options, if the patient is unconscious or not able to follow directions as well, include glucagon, or which is could be given sub-Q, IM, or IV. Sometimes people carry it, or even different institutions like nursing homes or long-term care facilities might have emergency glucagon, which almost looks like an EpiPen. It's the same kind of thing where you just, give somebody a quick injection. So if the patient is unable to swallow, no IV access, you can give that glucagon. However, and put stars around this, if the patient is starved, maybe they have an eating disorder, or maybe they have, cancer or end-stage AIDS, and they have muscle wasting and they look really, really thin, then glucagon is not going to be very successful, because somebody who is starved will not have stores of insulin. Oh, sorry, stores of fat. I don't know what my problem is today. I guess I need more coffee. Anyone who is extremely thin with muscle wasting is not going to have stores of sugar in their liver, which is what glucagon does. So if you remember back to the slide where we were talking about maintaining the blood sugar level, if the blood sugar gets too low, glucagon is released to free up our storage areas in the liver and fat. But if the patient is so thin that they don't have any storage, then glucagon will not be successful. So that's always a test question. The person that isn't a good candidate for oral intake, can you give glucagon? And the answer is no if they're really, really thin, because it's not going to work. The best and quickest way to take care of it is to actually give IV dextrose D50. That'll be the fastest way to bring their blood sugar up. And you will need to check again in 15 minutes because it's possible that it'll drop again. So they will need extra monitoring. So be sure you're aware of the symptoms of hyper and hypoglycemia and what the person's plan could be or should be for a decrease in blood sugar. So the first set of medications are the medications that are in particular given for type 2 diabetes, and these are the medications by mouth or the oral hypoglycemics, and these are the medications that'll be on your quiz next class. So that means for the quiz, slides 15, 16, 17, 18, 19, 20. So slides 15 to 22 are the slides that you should study for the quiz next class. So we're talking about the oral hypoglycemics. They're taken for only use for type 2 diabetes. Type 2 diabetics may end up needing insulin later, but we usually start with oral hypoglycemics. You could never use oral hypoglycemics on a type 1 diabetic because they're not making insulin at all. So they only can take insulin. Some of these medications are taken alone or in combination. The general rule is you're always concerned about hypoglycemia, some more than others, and so you need that plan. And the general rule is any diabetic really should not be drinking alcohol. But some of these oral hypoglycemics are affected by alcohol intake. They have that same reaction that we've talked about a couple of times, which is the disulfiram reaction, where they feel sick in combination, that flushing, headache, nausea, vomiting, and then they end up, my blood pressure changes. Does somebody have a question? I hear somebody. It looks like Lakeisha. Oh, okay. We fixed that. All right. So the first oral hypoglycemic is in a class of medications called sulfonylureas, because there's more than one of these. Our prototype, so the one with the little star there, is glipizide. That's the one you'll see on the exam. And this medication tries to tell the pancreas to make more insulin. And release more insulin, because we know that one of the reasons why people develop type 2 diabetes is their pancreas just isn't as sensitive to the increase in blood sugar. So this medication is telling the pancreas to release more insulin. And it's taken once a day, daily, 30 minutes prior to a meal. So it depends on the patient's schedule. As you know from that community pharmacy project, if the patient doesn't normally eat breakfast, then that's not a good time for them to take it. But if they're lunch, then do it with lunch. It just should be one time daily, 30 minutes prior to a meal. Common side effects are nausea, diarrhea, and mild hypoglycemia. Adverse will be severe hypoglycemia and hepatotoxicity. So just a quick reminder, what is hepatotoxicity? What are those symptoms? Jaundice. Yeah. Okay, so we got a lot of jaundices because that we know not typically rash. That's more of an allergy. Yes, there would be a change in blood tests, and that would be liver enzymes. So we would expect the patient who's having issues with their liver will have abdominal pain, particularly in the right upper quadrant. Yes, that's also true, Nicole. And signs that they're not handling the bilirubin correctly, which means in their skin, they might increase the amount of bilirubin they release in their urine, which is dark urine. They could definitely have yellowing in their eyes, and they might be passing more bilirubin in their stool, which makes white stools. And then if we suspected that, we would get blood tests, and that what Scott is saying is the correct blood test we would check is liver enzymes, particularly ALT and AST, as well as the bilirubin level. Alcohol and NSAIDs can increase the risk of hypoglycemia. So give me some examples of NSAIDs. Ibuprofen. Prednisone is a steroid, so it's not considered a non-steroidal anti-inflammatory drug. But prednisone can increase hyperglycemia for sure, so it's not completely out of left field to say prednisone. We certainly would have to worry. Tramadol does not count as a non-steroidal anti-inflammatory. It's a weak opioid, plus it affects serotonin. Aspirin would count. So non-steroidal anti-inflammatories include things like ibuprofen, naproxen, and aspirin. And ibuprofen and aspirin were the two that we talked about in class. And then this medication has that disulfiram reaction. A similar medication to glipizide is repiglinide. It's a slightly different chemical makeup. It's a different family. And the biggest difference between is that the dosing is different. So again, we're doing the same thing that glipizide does. We're trying to tell the pancreas to release more insulin, because the pancreas isn't as sensitive to elevation in glucose, except this medication we have to take 3 times per day, 30 minutes or less before we eat a meal. So if we only eat 2 meals, then we just take it twice. We only take it with the food that we eat. If we're like a hobbit and we have second breakfast, you could take it more than 3 times, but no more than 4 times per day. Right, Leo, we talked, you might have missed this, but I was having trouble loading these. I think because of all the recordings, I've filled up the data for our site, so the slides are under the calendar invite in Outlook. No problem. So the main side effects are nausea, diarrhea, and mild hypoglycemia. So repiglinide is kind of nice for someone that doesn't have a consistent schedule, because they can take it on days, if they're not going to eat a lot one day or eat more the other day, and it doesn't react with alcohol the same way, although no diabetic should be drinking alcohol, and it does not affect liver function. So some people would prefer this one. Some people would prefer glipizide if that means that they only have to take something once a day, because maybe that'll help them be more compliant. So it kind of depends on the patient. Our next is metformin, which is part of a family called biguanides. And metformin is very commonly prescribed for diabetes, and it is often used in combination with other diabetic medications. So metformin is definitely a medication you will give out to patients a lot, or talk to patients about. This medication works differently than the first 2 meds we talked about. It does not do anything to the pancreas. It does not tell the pancreas to release more insulin. Instead, it changes how we absorb glucose, hoping to decrease the amount of glucose that we absorb. It decreases the synthesis of glucose in the liver, meaning it decreases glycogenolysis, because we don't want to release the stores. And it reduces insulin resistance on the cell level, so the cells respond better to insulin than they were doing before. So then you can see that it would be good to combine some of these other medications. I can use metformin with glipizide, which commonly there's a combo for that, because that works in a different way. And so if I use glipizide and metformin together and to decrease my blood sugar, because they're working together, but I don't alter any of the doses, they stay at the same doses, what kind of drug relationship is that? So glipizide and metformin are taken together. I don't change the doses, but I do bring the blood sugar down more. Additive, yay! Because I know that it's not synergistic because I didn't get to change the dosing at all, but I did get to have an added benefit by taking them together. So I'm glad that you remember that because that was from our first class. So you can take this medication 1 or 2 times per day. It depends on whether or not you're taking an extended release form. Always have to worry about hypoglycemia, although it's a little less for metformin. People will notice, and this is often the biggest complaint when you first start metformin, is nausea, vomiting, and diarrhea. And it's probably because you're changing the way the body absorbs glucose. And oftentimes people will be like, I can't take this, it's too uncomfortable. But if they stick with it, then those symptoms go away over time. So they just have to keep with it. Metformin can change the way some of the B vitamins are absorbed, so the person can develop a particular type of anemia that's related to the B vitamins. So we have the symptoms of anemia that we've talked about before, where the patient feels tired and they're pale and they might be cold and they feel weak. The difference is other anemias don't cause the cherry tongue or a change in appearance of the tongue. The other big issue with metformin is that it has the possibility of causing something called lactic acidosis. Lactic acidosis is a metabolic reason you increase the amount of acid in the bloodstream, and for metformin it has to do with changing the way the kidneys are working, and because they're supposed to eliminate some of that acid or hydrogen in our bloodstream. And people are more prone to lactic acidosis if they have something else going on, especially if they have any trouble with their kidneys or they are going through some sort of illness on their own. Then when you give them metformin, they have an increased likelihood of lactic acidosis. And because that can increase with stress on the body, surgery is one of the things that can trigger lactic acidosis, as well as contrast, because that increases a possibility of kidney damage. So anyone who's getting a CT scan or some kind of scan where contrast is used, or anyone having a surgical procedure needs to hold metformin before and after those procedures. So that's very important, because this is the time that another time the person would be at risk of lactic acidosis, besides the fact if they were ill. So please be sure to remember that they'll always be on any kind of exam where metformin is involved. So we'll stop there and then finish the rest of the hypoglycemics and the rest of diabetes when we come back from lunch. So we'll return at 1 o'clock to finish the endocrine stuff. So on the schedule it says diabetes case study, but we won't do that right away when we come back from lunch because we haven't finished talking about diabetes. So we'll do that a little bit later. So please return at 1 o'clock and have a good lunch.